Hello, Madam Minister. Hello, Guy. Yes. Hello to everybody. We can hear you. I know you have a very busy schedule, so thank you for being with us. So the theme about the aspiration of citizens will be the first one. Philippe, or perhaps I will start with Switzerland. We will interview you. You're an extremely rich country. You spend 12.5% of your GDP on health, and you're the second country in the world after the US, ahead of France. And yet you have 26 cantons with the 300,000 inhabitants in each canton on average, and they have their own autonomy, even in terms of health care in each canton with respect to the federal government that you represent. Thank you. I think it's always complicated to try to explain the Swiss system, despite our small size. As you have said, there's an extreme wealth. We don't like to hear ourselves referred to always as extremely wealthy. That's not always a very pleasant introduction for us. Well, we speak more slowly than the French, but I can't explain the entire complexity of our system here. It would take too long. But the first aspect that I'd like to highlight is that our organization at 3 levels. The canton is the intermediate level, and it has a responsibility that's extremely important in terms of care and health. So the competency is that of the canton. The second element that is very important for us and that characterizes our healthcare system is the number of players, private and public actors, who have to find a balance within the system. And the third aspect, I will also refer to our direct democracy cliche, not just a cliche of wealth. So the citizens participate in a lot of our decisions. And yes, did you want to react to this idea of direct democracy? When I look at our big regional health agencies that are so complex, could we go further into freeing up energies in France? Well, in reality, in Ma Santé 2022, our program, we've really given more space to patients in the territorial diagnosis that they have to carry out of healthcare needs, and also to the elected officials, we're giving more of a role. So we're convinced that this type of direct democracy should also be deployed more in France in the framework of these regional health projects, regional contracts. It's based on these foundations that these ARS agencies should work on their healthcare offer. But we also need to diversify the profiles so that there are more elected officials who participate. Thank you. Now, in terms of aging and taking care of the dependent elderly, what does the Swiss federal state do with respect to the cantons? How do you share the tasks? Well, as I said previously, what is important to understand in our participation and distribution of tasks is that health is firstly incumbent upon the cantons, who have the responsibility to the population. And then it's the federal state that only intervenes when it's absolutely necessary. Now, perhaps to come back to the question that preoccupies us during this debate, for me, it's always interesting to go outside of Switzerland to compare systems. And when I came here, I was trying to think to myself and wonder what differentiates ourselves between the way we organize in Switzerland and in France. And I was a bit confused about this question and the title of the debate, because for us, it doesn't make sense to separate citizens' aspirations with management imperatives. I think these are things that go together, hand in hand in Switzerland. And when we look at task distribution, the citizens, with respect to healthcare, don't have, there's no difference between a perfect quality healthcare and then the state who's in charge of organizing it. I think the citizens think this all goes together. So maybe I perceive a very intercultural difference in our approach between France and Switzerland, because in Switzerland it's normal. Yes, you're right, you are an exception. And it's the opposite. You're at 75%, I think, of private financing by private insurance companies and 25% public financing, whereas for us it's 78%, we can say almost national funds and 13% of private financing. Yes, the insurance companies are entirely private with state regulation. So for us, it's very difficult to control the costs of our healthcare system. And for example, the Swiss citizen pays today about 10,000 Swiss francs per year for his health, whether paying these insurance premiums or participating in a certain way to the costs, which translates into about over 9,200 euros. That's twice as much as the French, yes, more than twice as much. So I think it's not simply a different perception, but there's a real link between the citizens and the cost of healthcare. Maybe we'll leave Switzerland for a few minutes to arrive at Denmark. KRONIG, you're my favorite participant of all of the speakers at CHAM this year, because in Denmark, you have modernized the hospitals, and you'll tell us a bit more about the money that was invested in recent years. You had to repeat it to me 3 times for me to believe it. You've regionalized the system, and there's a real balance between private medicine and hospital medicine that we're trying to do in France, but you've succeeded. You've integrated digital. So we've debated these subjects in France for so many years, these organizational topics, and we haven't totally achieved this progress, but you've achieved all of this. And so can you tell us more about how you did so?
The system is free of problems, actually, but it's a very simple system, the Danish system. It's a one-payer, public tax-based, organized system with free and equal access. And the money comes 100% from the government, and it's going through taxes, ordinary taxes. However, we are also decentralized. We have 5 regions with direct elected politicians, actually, to care about value for money and quality in a daily basic. So the organization is very simple. Our private system is about 2 to 4% of the production, actually. It's a public-based system. But we are not free of actual problems, and on the long term and the long hand, it's more or less the same problems that you have in France and in Switzerland, with a growing population, a growing elderly population, chronic diseases, who's actually rising with 70% of the coming 10 to 15 years. I think it's almost the same in all over, even the western part of Europe. We have an increase in cost of medicine of around 60 to 70% in the coming years. We have a pressure of service from the population, and the innovation of new drugs, new medicine, etc., is stressing us, of course, when it comes to fiscal policy.
Alors, Madame la Ministre, qu'est-ce que vous en dites?
Madam Minister, what can you say about this? Well, I'd like to recall that the health care minister in France, who started the reforms in 2007, became the prime minister. He's no longer the prime minister. But what do you think of that, Madam? Well, that's a question that I didn't anticipate at all. Today, I'm very busy with the Ministry of Health and Social Affairs, as you know. So I'm very happy to be in this position. It's an extraordinary ministry. We talk a lot about health, but solidarity is also a magnificent task where there's a lot of work to be done. So that's my answer. Thank you for this answer. Very rapid, Madam Minister. There's something that Vallalancien might like to hear now, which is when we talk about nurses. Not only are there twice as many nurses as the average in Europe, but also you have given the nurses a role that is quite different from the role that we give them here today in France, even though things are changing, and the minister can tell us more about that. There are things in the pipeline, but can you tell us more?
Down an average length of stay in hospitals down to 3.2 days, actually. And the nurses in a Danish context is highly skilled and highly educated. It's 4.5 years on top of high school. So the nurses actually are quite skilled, and that's the reason why we can sort of concentrate care and care in the hospitals down to 3.2 days, and even in oncology, for example, we are down about 5 days.
Je pense que ça doit vous inspirer, Madame la Ministre.
I think this should probably inspire you, Madam Minister. Yes, I'm hearing that. That's the direction that we want to take. We believe that we don't propose enough career possibility to the paramedical professions and healthcare professions in France, and yet the skills are evolving in all of the countries around us, and this is the direction that I really want to take, and I'd like to thank Guy Valencien, because Guy, you've been telling us this for years, that we need to have intermediate professions, and so we did create the advanced practice nursing degree for chronic diseases with patients who have cardiac failure issues or diabetes. We are opening up in the emergency medicine. I think we talked about this a few years ago in CHAM. It was your real combat, Guy, and I agree with you that we need to promote these nurses, and this direction is vital. We're trying to take it more rapidly by proposing task delegation with cooperation protocols that can be set up very rapidly without even waiting for these nurses to finish their 2-year training, additional training that will be governed by the law. Yes, we had some very interesting examples yesterday with Canadian and British nurses, surgical care nurses. And in Switzerland, where are we? You have an equal number, twice as many as those that we have in France? Or do you just concentrate on the doctor? We've really tried to place the accent on the possibility to encourage the nurses. At this stage in Switzerland, we have a very comfortable situation where we welcome also a lot of foreign healthcare staff. Despite our belonging to the European Union, we are in the center of Europe, and so we also attract a whole series of foreign staff. We're now starting an initiative with nursing care, the way we can supervise it better, and we're starting discussions with the population thanks to our direct democracy system. And I think the fact that the WHO has declared next year as the year of nurses and midwives, I think this will be in 2020 a topic that preoccupies us at the national level to see how we can respond to the needs. There's a big debate today in France, which is the question of the emergency wards. We've talked about this in our previous roundtables, and we see that this crisis in the emergency ward is a symptom of a malfunctioning upstream and downstream, and we see that the emergency wards in themselves can be improved, but it's the entire system that needs to be improved. And there's an article published in the European Journal of Emergency Medicine 3 years ago, which summarized your reform in terms of the emergency care, and it showed after the reform that it was minus 25% of visits to the emergency wards in the 3 or 4 first years after your reform. This is almost a miracle, minus 25%. In reality, this really saves an organization that is encountering difficulties. How did it work?
The article, unfortunately, but we have a sort of double system when it comes to acute care in Denmark. The first system is actually the GPs organizing themselves 24/7, who takes the first sort of front of patients who with less damage or less sickness, and the other one is the acute wards in the hospitals. What we did actually a couple of years ago, and it's still an ongoing process actually, was to concentrate the acute care units to less units, and in these units actually to turn around the doctors so the specialist was in front. And that creates actually a system where you avoid people who are not sick enough to come into the wards, And when they come there, you can do exactly what is necessary in the ward with the highly specialist or highly acute specialist, actually.
But is it possible for a single patient to go directly to the emergency department without seeing a...
Formally, no. But if somebody comes there, we'll sort of tell them to go around the corner, actually, where the GPs are organized. We organize it that the GPs are very close to the hospital walls. But if an acute patient comes directly to a ward, of course we'll bring her or him in. But you can formally not go there, actually, unless you are through the first-line system of the GPs.
Et en Suisse?
What about Switzerland? I think for us, we really, in recent years, tried to work on two elements. The first dimension is how can we control the costs of our system, but the costs, quote-unquote, superfluous cost, not the cost of the aging of the population or the costs linked to innovation, medical innovation, but really the costs that we should be able to avoid, because we believe that this is a dual responsibility to guarantee our social contract and make sure that we don't only have a system of good quality, but also a system that is sustainable in terms of its financing. And we realized that this was something that really preoccupies the population, and it is a real source of anxiety due to the growing costs of our system. And the second emphasis that we placed was how to work on quality, because I really believe that despite the cliches that you apply to Switzerland, and this was the case when you say we're so wealthy in Switzerland, but the level of quality that people imagine has to be effective. And so in terms of patient safety and the way you can improve the quality in our healthcare system and in our hospitals, this is a real focus that we have preferred. Next year, we'll have a summit on patient safety in Montreux, not far from here, and we'll really be trying to work on this aspect. And if you allow me, in this respect, maybe one last comment. I really believe that we're in the discussions about emergency care, we're always focusing on how to react when somebody's in a very acute situation and how to react rapidly. But in our challenges in terms of healthcare, I think the questions of chronic disease are actually our main source of worries, because that's where our main costs are generated, and not really because somebody would go to the hospital for a wasp bite or something.
What about chronic diseases? They are handled in city center, at the GPs, not at the hospital.
Very big also in a Danish context. I think one of the plans we have, we discuss it actually these days, is how to cope with that. And the working plan right now, it's not politically at this moment, but the idea is actually to take 10–20% of production out of the specialized hospitals in the coming 10 years. And what we do actually is sort of a reverse quality plan, where the medical agency in Denmark has been asked how many patients actually on the ward of diabetes can be treated elsewhere. And the answer is 75%. And you can just go through all the diagnoses actually. And what we do about that plan is what is the municipalities and the GPs actually then going to do in the coming 5 to 10 years to cope with the problem. Otherwise, the hospitals can't cope with it, and that will take money out of the highly specialized functions in the hospitals. So this is a medical plan, but it's also a economical plan, and it's a social plan also, because the chronic deceased actually are closer to home.
Chère Agnès, c'est intéressant. Pourquoi on a pris la Suisse et le Danemark?
Dear Agnès, it's very interesting. Why did we select Switzerland and Denmark? Well, it's because their funding system is totally different. you mentioned the cost of 9,000 euro in Switzerland, 4,500 euro per inhabitant in Denmark, and we are at 3,000 euro for identical results. So who is right? What does the minister say to that? Who is right? These are huge differences in funding and in organization, in planning, and still we get similar results in the three countries. It's strange. I must say I did not hear everything because the sound is poor, but we have two very distinct systems in Switzerland and in Denmark, and the systems are different and the results are about the same. But these countries are different. The reality is very different in each country. In France, we have disparities, geographical, social disparities, and it's difficult for us to harmonize access to health. We cannot compare ourselves to a country like Denmark, which is more homogeneous in terms of population. They don't have the issue of medical deserts that we have in France. So each country has to find their own solution with the offer that they have, with the professionals that they have, and each country much adapt its system to its geography and social circumstances. There's a saying that goes, democratic people have a natural taste for liberty, but they have for equality a burning passion. And that really describes France. We starve for equality. We've heard that throughout the social crisis we've experienced the last few months. So we really want to promote social and territorial equality. We want each territory to be able to have its own solution, their own solution, adapted to precise local needs. You are right to say this. French people are full of contradictions. They want revolution, but not too much. Change, but not too much. Stability, but not too much. We want homogeneous access to health, and that should perhaps go through regionalization. Yes, we need some degree of regionalization, whether it be regions, departments of communes. They have a role to play because they're close to their populations. They know populations' needs. They have a strong role to play in terms of prevention. They know where the difficulties lay. Now, we want all collectivities, all regions to be able to handle their health issues. But what I am against now is a regionalization. We do not want regions to manage expenditures and benefits. It would end up in a country with competition between the different regions. It's what we see in Switzerland, with some regions trying to attract more doctors or nurses. There's a strong competition. And this is an issue that we have in our trans-border regions with Switzerland. Our professionals are attracted by Switzerland for obvious reasons. We don't want this competition to exist within France between our different regions. Those regional differences, the state has to surpass them. We have to act to overcome that problem, but the regions have their role to play, including with ARS. We are going to be very pragmatic. In Switzerland, on average, a GP earns how much, and a nurse how much on average. In France, it's 78,000 euro for a GP and about 20,000 euro, perhaps 25,000 euro for a nurse. As Mrs. Minister said, rightly so, we are extremely decentralized. So we have 26 regions. I have 26 answers. It really depends if people work in a private hospital, a public hospital, and in which canton. Well, I am a urologist. Where should I live, in Zug or in Geneva? Urologists are not those who are the worst paid, and you will be better off in Switzerland. I knew that. So how much is paid a GP? And how much is paid a nurse in your system per?
Going from the Danish kroner to euro, I think a GP in Denmark owns about 200,000 euro in an average. That's a high figure, but they are very productive. And the nurse actually in Denmark is around, I think, 45,000 euro.
Il a dit, but they are very productive.
Yeah. But actually, when it comes to competition about the regions, you could, as a minister, lower that competition. Actually, how we did it in Denmark, actually, because the national agency, medical agency in Denmark, provides a plan for the 20% of highest value, actually, and telling the regions actually. No, you are not going to do open heart surgery unless you have XXX patients, actually. So that could be a tool, actually, coming to sort of limit the competition between regions or elements, actually.
Je le dis sans amertume, la France ne brille pas par le niveau.
So France does not stand out in terms of GPs or professionals' revenues. Well, in France, we sometimes have simplistic views. People keep saying we must raise the number of beds in hospitals. We don't have enough beds. I'm convinced of the contrary, but I would like to know what you think about this, and I will provide one figure. In the EU, you are the country with the highest ratio of doctors and nurses per hospital bed.
More or less natural, because when the patient is in there, we are very concentrated with the highly specialized service, medical service, and nurse care. So you have to have a ratio who is actually very, very high. And we are down to 3.2 in an average length of stay. We have another tool actually these years, we call it a super hospital plan. And that is also to bring up productivity actually. And what we did, and that is a governmental tool actually, and the government who actually was the chooser of what hospitals should be rebuilt. And that's a program about, if you compare it to France, it's 40 billion euro in new buildings laid down on top of the investments actually we have today.
In 10 years?
Euro.
In 10 years?
That, well, they can sort of start as soon as possible, but it takes 6 to 7 years actually to finish a new hospital today, from the idea to the patients coming in.
Nous allons poursuivre.
We are going to keep going. Let's ask Agnès BUZYN to say what she has to say, but I would like to ask her a question first. On the basis of what you did in the past, and I must say, very friendly, that we are very admirative of the courage that you had on some actions, including vaccines and homeopathy. You really were strong and facing the opinion, which had a very strong, with very strong voices. So congratulations. Now, all remains to be done. You started the work. Now, how do you foresee change in the future with the new fluidity that we will have? The philosophy of My Health 2022 is to trust local actors. We have to stop thinking that the state can regulate everything from the top. We have to guarantee equality in access to healthcare, but we also think that organizations, professionals must get a hold of the system. That's the spirit of the reform. We have some levies now to better coordinate caregivers on all our territories. So that's a major aspect of our 2022 program. Now, health professionals are ready for this declustering. The emergence of chronic pathologies require this new approach. You cannot just take care of someone in the GP's office. You need pathologists, physiotherapists, and so on. There's a strong dynamics in place. It started, and the first contracts were signed, and we are putting some money on the table for this transformation. Moreover, there is a chain of services, and GPs have a new role now. They need more time to be with their patients, so some tasks must be transferred onto other professionals. It is necessary in terms of quality of life for doctors and for patients. Collective organizations, that works really well. Young doctors want to work in health centers, plus 37% in 2 years. So I really trust this. I think we're on the right path. Now, hospitals, they must be refocused on their added value, and we suggest a new organization of hospitals with a gradation in care. It was a nasty word a few years ago. Now it's becoming mainstream. Some small hospitals are the first door that patients are going to push. They are necessary for the service of our citizens. So there will be a change in costs for patients in such small hospitals. I'm convinced that we must invest in hospitals, in premises, in equipment, because we want the staff there to be happy to work in hospitals, and we want to better organize the work within hospitals. That should be more in the hands of professionals. The law is on the right path, but we're going too far away in terms of governance. Now we must find a dual solution. We must refocus hospital projects around medical projects, chains of care, and not just administrative or financial aspects. And this is a component of the law for Health 2022. It gives a priority for hospitals. They can focus on care and not just on financial aspects. So we have activated many levies in the framework of My Health 2022. We have a lot of support, a lot of commitment. We are creating intermediary professions, as Guy Valencien is inviting us to do so, and has been doing so for many years. We talked about professional chains for many years, and we talked about remuneration. I am in favor of reviewing the revenue for medical health professionals. We also have to review skills. We have to take into account changes in practices. It's not just about giving money without declustering things. So this is what I want to promote in the years to come. Thank you. Do you want to say a word to Mrs. BUZYN?
That I hope you succeed as as other ministers of health in the coming year. It's a tremendous challenge, actually, and I think and I really agree with you that there is no such thing as a fix it must be hard work on a lot of elements in the coming years. So yeah, I hope you succeed.
Nora KRONIG.
Merci beaucoup. Je crois que en arrivant dans la discussion, je m'attends.
Thank you very much. I was expecting to hear about huge difference in systems, in how we manage our systems, but basically there are two things that are common. When we build a health system, we have our own culture. All of us want to optimize our organization. I think that there's an optimal degree of decentralization. We are very different in this, in France and in Switzerland, but sharing experiences is always interesting. And I think that all of us, the three of us here, really want resources to be ideally allotted to the various sectors and needs. So let's see how we can inspire from each other. Thank you so much. Thank you, Mrs. Minister. Thank you, Agnès. Thank you, Mrs. Nora KRONIG. Thank you, Pierre OKKELS.